Hello, good morning. Can everyone hear me? Okay, excellent. Well, good morning and welcome to the 2025 Community Liver Alliance National Liver Gathering. And also welcome to Pittsburgh. Yes. So I'm Susanna Massardis, the CEO of the Community Liver Alliance, and I'm honored to welcome you to our first convening of the National Liver Community. You know, at its heart, this event is about amplifying the voices of patients and their caregivers and assuring that your insights and your voices are shaping research, informing clinical practice, and driving policies that improve the lives of the liver community. And this is a scientific meeting, yet it's grounded in evidence and expertise, but it's defined by the patient and the voices and experiences of the patients and the caregivers. And too often, there are gatherings where patients are invited to attend, but they're not at the center of that. And this was the gap that we saw. And so we appreciate everybody who has been a part of planning this first event. And this gathering closes the gap and strengthens collaborations and advances progress that will truly change lives. And the inspiration for this really came from conversations with patients and patient groups and our colleagues at patient advocacy organizations. And we wanted to make sure that everybody's voice was brought together, including industry partners, which we felt was really another lacking piece of the puzzle. So that's why we're here today. And our vision is to continue convening this diverse community year after year and to set priorities, shape solutions, and move the field forward in a way that not only is evidence-based, but also patient-centered. We firmly believe that we are stronger together. This is a mantra that the CLA team uses often. And when science, clinical practice, innovation, and lived experience intersect, progress accelerates. Patients remind us of what's at stake. Researchers bring the data, providers bring practical application, and industry partners bring innovation and scale. Each role matters, each voice matters, and it's only by working together that we can deliver meaningful change. So before we begin, I'd like to highlight a few important things for you. First of all, Clayton told me to make you aware that breakfast ends at 9:15, so if you haven't grabbed your breakfast, you should do so, and coffee, but we'll have breaks throughout the day as well. We want to make sure that you take time during the breaks to visit our exhibitors, and because they're the vital part of this. We wouldn't be able to host this event if it weren't for our funders and our industry partners. So make sure that you visit their exhibits. And also, as you see around the room and here, we have our patient advocacy organizations represented. And we felt it was really important to make sure that they were here around this room so that you could all connect and they could connect with you. So making sure we have those different conversations. But we have the passport. And so make sure that when you visit that, the exhibitors sign your passport, because we are having a drawing for an iPad every single day of this conference. So somebody will have a chance to win an iPad each day. And this year our program is fully digital, so you can access anytime the program with the QR code. It's 96 pages. Aren't you glad we didn't print that and hand it to you? And at the end of each day, we ask that you complete a short evaluation, and your feedback is invaluable. We really need that feedback so that we know how to continue to grow this event, to inform us on what you want to learn, what you liked, what you think we could do better, what you want more of, or something different. And I also want to take a moment to thank, first, the CLA team. Michelle and Joe and Pam and Meredith and Clayton, All of our team is so amazing, and if it weren't for these incredible people, this wouldn't happen. I mean, they are just amazing behind the scenes and making this a possible event, and they really do make a difference in our mission. So thank you, CLA team. And I want to also recognize our generous sponsors, Madrigal, AstraZeneca, Boehringer Ingelheim, Eisai, Eton Pharmaceuticals, Gilead, GSK, Intercept, Ipsen, Mallinckrodt, Pharma, Salix, Servier, Takeda, and UPMC. That's quite a list. We're so proud, and we want more, so we need more partners. And we also want to recognize our patient advocacy organizations, and make sure you do visit them as well. We have the Fatty Liver Alliance, Imani Unidad, the LAL-D Aware, Liver Education Advocates, Mid-South Liver Alliance, the PBCers Organization, PFIC Advocacy and Research Network, and the Wilson Disease Association. Sober Livers, I'm sorry. This is the problem reading the names, right? We cannot forget Sober Livers. And we want to also recognize our expert planning committee for shaping such a meaningful agenda, and to our distinguished speakers who have so generously shared their time and expertise and insights by contributing their knowledge. And we can only strengthen our dialogue within this room by learning and listening and sharing. So we appreciate it. We have expert presenters from across the nation. It's truly a national endeavor. And so we're very excited to have all of these people with us for 3 days. So over the next 3 days, this gathering will be about connection, about collaboration, about impact. And I encourage you to listen deeply, share openly, and question boldly, and most of all, build relationships that extend far beyond this room and these walls. We must begin to really carry this momentum forward. And I also want to let you know that I'm eternally grateful. This was a vision that we had, and I've been wanting to do this for so many years, and that we've brought it to life together. I just thank you so much from the bottom of my liver. I am very grateful to all of you for making this possible. And today is Community Liver Alliance Liver Gathering Day, and we have a special guest with us, Pamela Collier. She is a special assistant to the office of the mayor, and we would like to have Pam come up and read the proclamation before we begin our program. Please join me in welcoming Pamela.
Who was that that's so encouraging? You're like my mom. Hey, thank you. First of all, I just want to thank this organization and all of you good people in this room for all of the work that you're doing. Liver challenges had never been a part of my orbit, and then my friend's sister, who I adore, got somehow or another fatty liver, and I'm learning a lot that I did not know. So I want you guys to give yourselves an applause for all of the hard work that you do, the hard work this lady does. So Mayor Gainey sends his apologies that he cannot be here today, excuse me, but it is my honor and joy. I like when we participate together, because we're all better when we work together. So I am going to point at you, and you're going to say whereas. So we're going to do a practice one. Whereas the Community Liver Alliance, CLA, has established itself as a vital organization dedicated to improving liver health and addressing the challenges posed by liver disease and... There you go. The National Liver Gathering, hosted by the CLA, will take place in Pittsburgh from September 25th to the 27th, bringing together a diverse group of stakeholders, including patient advocacy, God bless you, patient advocacy organizations. Oh, it's the puppy. Hi, cutie. Oh. Healthcare providers, researchers, caregivers, policymakers, and industry partners. And I'm not going to make you read all of it, it's long. Whereas with liver diseases on the rise and disparities in care affecting many communities, the National Liver Gathering aims to promote meaningful policy solutions that will enhance prevention, diagnosis, treatment, and access to care for individuals affected by liver disease across our nation. Last one, I promise. The collaboration of patients, caregivers, healthcare professionals, and community leaders at this forum will foster a spirit of unity and shared purpose in the fight against liver disease. Now, therefore, I, Ed Gainey, and I promise you I'm prettier than he is, but I, Ed Gainey, Mayor of the City of Pittsburgh, do hereby proclaim September 25th through September 27th, 2025 as National Liver Gathering Day in Pittsburgh. And I encourage all citizens to recognize the importance of liver health and to support the efforts of the Community Liver Alliance and its partners in advancing research, education, advocacy related to liver health. Amen.
Thank you so much. Thank you, thank you. Does somebody want to take a picture of us getting this? Where's the pictures?
He's right there.
Thank you. Okay.
And I never get a copy. Could you send
Yes,
that?
we will
And
send you a
put it-
copy.
We'll put it in our little
Okay, awesome. Can you?
notebook. Yeah. You want to get on this side so that, there we go.
Thank you. Thank you, Pam.
Yes, have a
Pamela,
good one.
thank you so much.
Absolutely.
Okay. That was fun. She makes it so much fun, doesn't she? So, day one, we're starting off with our alcohol-associated liver disease sessions. We're so excited to bring this topic. It's so important. And we have the Sober Liver group and all the folks that are going to help us learn. And we want you to make sure that you're engaging with this group. It's my pleasure to introduce our keynote speaker, a pal, Alison Faust. Dr. Faust is a transplant hepatologist with UPMC Center for Liver Diseases and Care. And she is so amazing. Even though she had an accident this morning, look at her here. Just nothing stops Alison. She really is a firebrand. Honestly, she is. She's amazing and an inspiration. Her interests in research include viral hepatitis B and C, the genetics and genomics of liver diseases, predictors of fibrosis and cirrhosis progression, and treatment response. In addition to her clinical and research work, Dr. Faust has served as an expert speaker for the CLA many times in the past, and helping us to advance education and awareness in liver disease and to create a healthy community. Please join me in welcoming Dr. Faust. Thank you.
Oops, sorry, dropped that.
Is this the slide advancer?
You will just need to kind of arrow it forward because that advances for the.
Oh, okay. I'm so excited to be here. Thank you so much, Susanna, for that introduction. I sincerely hope anyone visiting is staying locally and didn't have to navigate Pittsburgh traffic this morning because it was a problem. And as she alluded to, I might have gotten in a little fender bender, but I was like, here's my card. I'm going to get going. In addition to what Susanna said, I'm also the director for the Liver Health and Recovery Program at UPMC. So we've started a clinic to manage patients that have alcohol-associated liver disease and alcohol use disorder. So I'll touch on that a little bit, but it's not necessarily an advertisement for that. But I wanted to add that in as well. I'm so honored to be here today to talk about trends in alcohol-associated liver disease. So excited to kick off such an innovative and needed conference. So thank you again. During the talk, I'm going to depress you quite significantly with the global burden of alcohol use disorder and alcohol-associated liver disease. But I hope in the second half, I'll kind of pick their spirits back up by kind of talking about things that we could do. First at a public policy level, and then at an institution level, and then finally at an individual provider level for anyone that may be taking care of patients that have alcohol-associated liver disease. So, the global burden of alcohol-associated liver disease. It's bad, and it's getting worse. In 2019, alcohol consumption itself, so we're just talking about alcohol use to start, it was the 8th leading risk factor for global mortality and leading to 2.4 million deaths. 4.3% of total deaths in the world were related to alcohol. And harmful alcohol use contributes to over 200 medical conditions. We're seeing a lot of rising rates of cancer and some links with even moderate alcohol use and association with cancer. This is a map showing alcohol use disorder globally. You can see that the darker the blue, the higher the prevalence of alcohol use disorder. And you can note some of the countries that are really dark there. But the United States kind of falls in the middle blue section of prevalence. Global alcohol use is also rising, and one of the ways that that's measured is by determining something called the alcohol per capita consumption, which is the amount of alcohol that's drank within a calendar year in liters of alcohol in anyone over the age of 15. So in 2005, that number globally was 5.5 liters. In 2016, it was 6.4 liters, and it's projected to continue to rise to 7.4 by 2030. However, of course, we know projections have some limitations to them. Europe actually had the highest APC, but Europe's APC has actually been coming down with time. The two areas that had more of a rising prevalence of APC were the Western Pacific and Southeast Asia territories. So not only is alcohol use increasing globally, but alcohol-associated liver disease is increasing globally. In 2019, alcohol-associated liver disease resulted in the loss of 11 million life years, and the number keeps going up. It's the leading indication for liver transplantation in the United States and in Europe. And the graph here will show globally the alcohol liver disease prevalence based on whether it's the general population, which is the dark green, people with hazardous drinking patterns in the lighter green, and then with alcohol use disorder, where the prevalence of alcohol-associated liver disease of any kind goes over 50%. This is a map that's showing alcohol-associated liver disease prevalence. And if you remember back to the prior slide, if you have a good memory, then that's great. If you don't, like me, then I put them together so that you can compare them directly. So they don't actually completely look the same. So there's countries where there's a lot of alcohol use disorder, but there isn't as much alcohol-associated liver disease. The United States still tends to fall in that middle blue kind of category, maybe a little bit lighter blue, but still pretty blue. And you can see some other areas kind of falling out there. So in terms of global trends, so like that last slide demonstrated, the alcohol consumption and the alcohol liver disease burden might not always match up totally, so there's a lot of variation by country. And some of that could be access to health care, some of it could just be reporting, frankly, but there may be social inequities or cultural factors that contribute to this. But this paper actually showed what the role of obesity plays in alcohol-associated liver disease prevalence by country. So the way that we're looking at this is on the y-axis, we're looking at DALY, which is a public health measure that kind of assesses the impact of a condition. So it's the sum of years lost from premature death plus the years lived with disability. So how bad is it kind of on the Y? And then on the X-axis, we're looking at how much alcohol is being consumed with that APC kind of value. And so you can see there's countries that have a really high APC but don't have a very high DALY. And then what they've done is also kind of separated it by whether your country is above the median for obesity, which is the lighter green, or if it's below the median for obesity, which is the darker green. And you can see that the darker green tends to be lower DALY, and then the lighter green tends to be higher. And so obesity is probably playing a role in this, but we can't ignore there's also genetic factors, smoking, there's all kinds of other risk factors that are contributing. But I thought this was kind of an interesting graph to show all of that relationship together. This was a paper, this is a graphical abstract from a paper that was published this year that looked at the global epidemiology of alcohol-related liver disease and alcohol-related liver cancer. And the picture of the map is showing the increase over that time period. So over 2 decades, how it's increased. The paper did say that there's 111 million cases of alcohol use disorder in 2021, which was a 15% increase compared to 2000. That there's 3 million cases of alcohol-associated liver disease, which was a 39% increase since 2000. And there was 132,000 cases of liver cancer that were related to alcohol, which was up 94% compared to 2000. 49 countries showed an increasing prevalence rate of alcohol-associated liver disease. And one of the things that came out was the COVID pandemic really contributed to some of this rise. And also what we've seen is that there's trends towards females being more affected and younger individuals being more affected by alcohol-associated liver disease. So the COVID pandemic really kind of impacted everything, as we've all experienced. There's documented alcohol consumption increases in the United States, the United Kingdom, Canada, Poland, and Belgium. A lot of people cited lockdown as a reason for a relapse when they had otherwise previously been pretty abstinent. Just talking to patients, I've heard a lot about how the lockdown contributed to their mental health and their alcohol use patterns. We saw higher severity of liver disease in hospitalized patients. That's probably very multifactorial. We know that you couldn't really get into the hospital very easily, so people kind of waited, and there was a lot of factors probably going to that. But we also saw a really significant increase in new listings for liver transplant for alcohol-associated liver disease. There was 107% increase in listings and then 210% increase in transplants for alcohol-associated hepatitis. Now, that's not all just because of the pandemic. I think that also over that time, we've become increasingly comfortable with the idea of doing transplant, and it's become more accepted at centers. Ever since the French did it back in around 2010, somewhere in there. So everyone, our country has really been adopting this more significantly. This is a graph that's just SRTR data from the transplant community. This is for the United States specifically. This shows your alcohol liver disease listing since 2012. And alcohol liver disease is that purple line that you see going up. You can see most of the diseases that we take care of have had a pretty steady rate of listing for liver transplant over time. Hepatitis C has gone down significantly thanks to the great treatment that we have now, but alcohol liver disease is just rising, and there was a 66% increase for listings between 2012 and 2022. As I mentioned before, we are seeing a lot of alcohol liver disease in younger individuals and in females. The increase in alcohol-associated hepatitis is most significant in that 20 to 40 age range, and mortality has risen significantly, especially in that group. This was a paper that looked at hospitalizations and liver transplantation for alcohol-associated liver disease. It's probably a little bit hard to see. I don't know if, does this have a pointer? I don't know if, oh, there. Okay. So this is the bottom line here. This is your young women. So you can see that still older males have probably the most burden of liver disease, but the second one is the rise over that period of time. And you can see how much the burden of disease has increased in young women compared to other groups. And then the second highest rise is in young men, ages 20 to 40, and that's hospitalizations. And then the bottom graph is the transplant rates, which is fairly similar looking graphs. So we're really seeing a lot of women and younger people being affected and being hospitalized and being transplanted than we had seen before. This was a paper that was published in Transplantation in 2022. This was looking at wait listings based on age group, sex, etiology, and it was basically showing that, again, like we mentioned, you're seeing a lot more liver disease in younger adults, so 4 times higher in younger adults than older adults, and you're seeing a lot more women that are being affected. So their conclusion was waitlisting is increasing substantially in young Americans, which is driven primarily by alcohol-associated liver disease, and listing rates are much higher in young women when compared to young men. This is the graph from that paper where, again, you can just kind of visually see that your alcohol-associated liver disease is this dark color here. I don't know whether that's black or blue or what color it is, but you can see how much most conditions are pretty stable, but you're seeing such a rise in the alcohol-associated liver disease listings for young patients. You see a rise in the older patients as well, but not nearly at the same scale that you're seeing in younger patients. So I think that should be the end of the depressing part of the talk. Hopefully that captured what we're up against. Really, it's a significant problem, and there are ways that we may be able to impact alcohol use, alcohol consumption, alcohol use disorder, alcohol-associated liver disease. So starting at the kind of public health level. So there's public policy modeling studies that project that the mortality from alcohol-associated liver disease will nearly double by 2040. Theoretically, aggressive public policy interventions that lower alcohol consumption could lower the rates of liver disease and dying from liver disease. But can we do it in the United States? And I'm not going to answer that question today, but I think we all know, probably know what we're up against in terms of the environment in the United States today. The World Health Organization laid out multiple areas of ways that you can reduce alcohol consumption in your population, but they identified 3 that were most cost effective, and they kind of called them their best buys, or the areas that we should really kind of be really focusing on, and that's pricing, marketing, and availability. So kind of going into each one a little bit more in detail, price increases in alcohol has been shown in countries that do this to be related to decrease in harmful use and decrease in alcohol-associated morbidity and mortality. There's 2 different ways you can affect the price of alcohol. You can either increase the taxes for alcohol, or you can enact like a minimum unit pricing, which essentially gives you a minimum price for end volume of alcohol, which really in kind of like easy to think about terms, like really makes it hard to get a huge volume of really cheap alcohol. It's really affecting like the cheaper alcohol that people could buy in bulk and really abuse. Taxation specifically, it has been shown in some studies to decrease mortality, but the amount of how much it decreases it is a little bit variable. As a business, you can offset the increased taxes by either lowering production or changing your profit margin in a way, and so so businesses can get away with not changing the purchase price even when you have a higher tax. And of course, we know that tax increases really affect patients that have, or people, not patients, anyone that has a lower income. So the effect of the tax increases goes up as your income goes down. This is kind of the most common thing that we do in the United States right now, but hasn't been exceptionally effective, and it's also not, the taxes haven't kept up with inflation. So actually the relative price of alcohol is less over the 30 years, which is interesting. So there's another way of affecting pricing of alcohol, which is the minimum unit pricing. Now this is really good data. My next slide has multiple studies from countries that have done this. It can reduce alcohol attributable deaths, it can save healthcare costs, it can decrease alcohol-associated liver disease hospitalizations. The only con I could really tell, and I just had to feel like I had to put a con, was that you pay more for cheap alcohol, but I mean, This is kind of set by state. So in the United States, the state can determine whether to do this. So Oregon actually has started doing this as of 2021, but we haven't really seen anything published from them yet in terms of how that has affected things. Michigan did a modeling study where they looked at if they increased the minimum unit price of alcohol by 13 cents, they could save like 350 lives. And so I think that that's a really interesting model that is kind of state dependent. These are all the studies that support using the minimum unit pricing as an effective pricing policy to lower harm from alcohol, including cirrhosis. So if there's one thing that I think that we may be able to advocate for that really doesn't have a lot of cons, I think this is an area that could be focused on. Second area from the World Health Organization was marketing. We know marketing changes behavior. We see it every day when we watch TV. The World Health Organization, as well as our liver, AASLD and EASL, all suggest that the government policies really try to regulate promotion at sports, standardize warning label messaging, limit advertising that targets vulnerable populations, which has mostly been youth, controlling content and volume of marketing, decreasing connections with youth activities, limiting use of digital media. And some studies show that advertising bans are associated with decreased mortality for liver disease. But marketing in the United States is, I think, tough for us to try to advocate to change. So it's regulated under the Federal Alcohol Administration Act. And then there's two different groups that are involved with trying to regulate the advertising. The first is the Alcohol and Tobacco Tax and Trade Bureau. But their focus is mostly on making sure that you're not deceived by the advertising, like they're not making claims that aren't true or something like that. And then you have the Federal Trade Commission, and their focus tends to be a little bit more on, let's not have this advertising targeting our youth. But we're not really regulating like how much advertising. You don't have to get approval to make an ad for alcohol. There's not a ton of regulation in terms of marketing. This is one of my 2 ChatGPT slides, in full disclosure, and it's not medical, so I thought it'd be okay to do. So I asked it, what is the impact, like what is the magnitude of the alcohol industry in the United States kind of compared to other industries? It's a $1.7 trillion industry, and it's comparable to non-alcohol beverages, pharmaceuticals, and luxury goods. The only one that's higher in this kind of like realm is the media and entertainment at 2.5 trillion. So we're dealing with an industry with a massive amount of money behind it. This was my second ChatGPT slide. So this is looking at advertising, like what the impact is. And so ChatGPT says that we don't necessarily know how much advertising changes consumer behavior. So we don't really know if like less advertising would lead at a population level to less consumption of alcohol. I think it probably makes sense that it would, but it does affect youth. Youth is particularly vulnerable to advertising. They're at a place where they're trying to be cool and trying to do the cool things, and I think that the more alcohol advertising, the higher the rates of youth binge drinking. And so within this kind of like realm, I found a stat that said there's $4 billion spent annually on alcohol ads. And a lot of it is, there's a strong influence on youth. And then the ads normalize it. It's like you see people like, I don't know if you watch TV, you see like someone had a hard day. Oh, I'm going to come home and like have a glass of whiskey or something. And it kind of makes that a normal behavior. And I think we are all susceptible to suggestion in a way, but youth are particularly susceptible to that. So they have seen that restrictions in advertising have lowered youth drinking rates, but not a lot of data in the United States. And I don't know that this is an area we're going to impact because look at how much money is behind it. And I think they have a pretty strong influence on things right now. So the third and final kind of area of public policy I was going to cover was the availability of alcohol. So the World Health Organization recommends having a national licensing system, monitoring production and serving, regulating hours and days where alcohol is sold, establishing a minimum age, And then any potential harmful policy is anything that increases the availability of alcohol. So this is state dependent in the United States. So we kind of all know, we're probably all from different states that have different regulations. Like sometimes, like Pennsylvania, alcohol's been regulated by the government. You had to go to a state store to buy hard alcohol. Other states might not be the same. If you drive across Pennsylvania, though, you can see that the availability has increased significantly because you can buy alcohol at gas stations, and that was not something that you could do a decade ago. But this is the slide that I think that was like the most remarkable to me, because this is how our family does a lot of football. We love football. We go to a lot of college football games. We go to Michigan football games quite frequently. And so Michigan started serving alcohol about 2 years ago, and I was amazed at how many alcohol stands they put up. You can't go, I don't know how many feet without running into a stand of alcohol. So the SEC started this, I don't know, sometime around 2010, just in terms of a statistic, not because we hate Ohio State or anything, but Ohio State started selling alcohol at stadiums in 2016. And they made 1.1 million that first year, 1.23 million the second year. And now we see that over 80% of college stadiums are selling alcohol. And this was a quote that I thought was like, just again, it's just a marker of what we're up against here. But athletic departments typically are not profitable, and this has been a way for them to increase their revenue stream. So they're worried about their profits. They're not necessarily worried about our liver health. So I think that's kind of the top level, public policy. And it sounds like, Susanna and the organization does do a lot of things with public policy. So hopefully, if that wasn't areas you're aware of, maybe that helps with conversations that you're having with your politicians and other stakeholders there. But I think at the level of what we can do as physicians, we're seeing this rise of multidisciplinary clinics for alcohol-associated liver disease and alcohol use disorder, and I think that's been a really nice way for us to feel like we're intervening more and helping people more. In general, when somebody has an alcohol use disorder, they interact with a ton of people throughout the healthcare system. They'll see their primary care doctor, they'll maybe see a hepatologist if they were referred, they're often seen in the emergency department. If they're admitted, they're seen by a primary medicine service, and then maybe a hepatology service, maybe even an addiction medicine service. And then on the other side of this is your level of alcohol rehab or alcohol kind of therapy-like programs, with level 1 being your outpatient therapy and medical management, so typically like a one-on-one counseling type situation. Level 2 is an intensive outpatient program where you might go 3 days a week or 5 days a week and spend several hours with a group really going through alcohol treatment concepts. Level 3 is a residential program that could be either medically or clinically managed, and level 4 would be inpatient care for alcohol use disorder. I think that, so sometimes kind of coming back to this idea of all these different people seeing patients that have alcohol use disorder, it's a lot of touch points with the healthcare people, so it could be a good thing if people are getting the same messaging throughout, but it doesn't necessarily seem like that's what happens. And a lot of the times I think you get a little bit of a not it, like someone else will take care of it kind of mentality. And I think that sometimes the more people you see, like even maybe the less help you're getting. What we've done at UPMC, before I get to that, there is some data showing that these clinics will lower 30-day readmission and mortality. And then after transplant, having a clinic that's really kind of comprehensively following someone can lower the rates of returning to drinking and lower the rates of post-transplant mortality. Small studies, I think we're just starting to get to know this kind of situation and its effects, but I think we'll be seeing a lot more of this over the years in terms of how we're doing with these clinics and how much they're benefiting people. This is the UPMC Liver Health and Recovery Clinic. You don't have to read all of this. It's just, this was an AI-generated mission statement, though, but it was really good and better than I could have done. But I think that the main message is that we want to lower the barriers to treatment, and we want to treat people holistically, but at an individual basis. So we want to meet people where they are, and we want to try to help. Now, I'm not selling UPMC specifically because I know that AHN has a great program as well. So both of your main hospitals in Pittsburgh have this as an option, which is pretty fantastic. They're cropping up mostly at academic centers around the country right now. Our clinic is on Thursdays. We have myself and a hepatology PA. We do the hepatology side, and then we have right now a counselor through the Western Psych group who comes over and does an assessment. So we've only been able to do 2 patients per half day. It's a pretty extensive evaluation process, but we've been seeing anyone with alcohol-associated liver disease and alcohol use disorder, no time frame of sobriety. So sometimes people are a year sober, but they still feel like they could use the support that they get from the counseling, especially if there's a mental health or trauma in the background. And or we have people that are still drinking and really still struggling. And I think one of the most meaningful things that has come out of the clinic for me is that people have had the trust in us to tell us when they're struggling. And they have been open about their relapses. And we've been able to pull people post-transplant that were transplanted for acute alcoholic hepatitis, that we've been able to have that relationship where they feel comfortable saying that they're struggling, and then we can ramp up our support. We are seeing pre, post, and non-transplant. Okay, I'm going to skip that because I really don't want it to be an advertisement for UPMC. But I think that's reflective of what other people, other centers are doing, and a great addition to how we're taking care of patients that have alcohol-associated liver disease. At an individual provider level, there are definitely things that can be done. This is my only slide on this. You can basically, all you really have to do is ask. So you can screen with a formal screening measure like the audit score or the drug abuse screening test. I just tend to ask. I mean, people come to liver clinic, I just kind of ask like really casually about alcohol use, and then I just asked, is there ever a period of time where you had more than 15, where you regularly drank more than 15 drinks in a week, just to get a gauge, and then I might go into it further, and that's a pretty simple way that you could address it. If you are concerned about someone's alcohol use, then just a very brief intervention discussing what the potential harms of that alcohol use are, and then making them a referral to treatment. So I encourage everyone to have a kind of a network, if you're a provider, to have a network of places that you might refer a patient to. But if you don't know and you just kind of need more guidance, there's a website through the government where you can find treatment. So, in conclusion, alcohol use disorder, alcohol-associated liver disease, it's a global problem and increasing with time. Public health measures can help, but I think especially in the United States, we have major barriers. This is a lot more successful in Europe. Multidisciplinary clinics can lower barriers to patient care and improve outcomes, and individual practitioners can practice the screening, brief intervention, and referral to treatment and get more comfortable with the prescription of medications, which I didn't go into today, but happy to review with anyone if that would be helpful. I'd like to acknowledge the many people that have helped me get the alcohol clinic going at UPMC. Also like to acknowledge my husband, Dan, who came today, who runs the household and allows me to be able to focus on this as a passion and a career, which I'm very appreciative of. And I always like to acknowledge, we had a counselor named Kristen Radich who very tragically passed away. She had helped so many patients that were struggling with mental health and substance abuse problems, and we miss her greatly, and our clinic is made in memory of her. So that's all I have. I am going to rush out at 11 to go see patients, but I think Susanna can freely provide my information if anybody wants to talk more with me about anything I talked about or the clinic or anything. So thank you. Can I just pull this out? It's not going to break my computer.
Wasn't that great? So amazing. Thank you, Dr. Faust. We appreciate you sharing your knowledge and your commitment to patients experiencing ALD and AUD.